All right, so now I'd like to introduce Graham Pash from the University of Texas at Austin, who's studying computational science, engineering, and math. He did his practicum twice at the National Renewable Energy Laboratory and will be presenting on towards predictive digital twins with applications to precision oncology. Welcome, Graham.
Thank you. All right, hi everyone. Thank you for the great introduction. So I'm Graham. So this is work with my advisor, Dr. Karen Wilcox from the Odin Institute towards predictive digital twins with applications towards precision oncology. A lot of words up there that I should define. I think the first one is digital twin. This is one of those words that when you say, I work on digital twins, people say, what is that? And then if you ask people that say they work on digital twins, you ask 10 different people, you probably get 10 different versions of what a digital twin is. So to just kind of get us all on the same page, I like this definition from the National Academies. And I like it because it highlights three key areas for me. So dynamically updated with data, predictive capability, and they inform decisions that realize value. So to me, these sound like the classical outer loop problems. We have forward simulation, we have uncertainty quantification, we have control and prediction, and then importantly, the bidirectional interaction between the virtual and the physical is central to the digital twin. So what might that look like? It might look like something like this. So a lot of work in this space is aerospace engineering. So they talk about physical assets. In healthcare, you typically don't call people assets, you call them patients. So we have our physical patient out there on the right side of the screen. That's the real patient, right? They have some disease, they exist in the world. We can only indirectly measure what's happening to them through these observational data that we acquire. In this space, it's typically going to be magnetic resonance imaging, so MR data. And then we come up with some mathematical model that we think describes how this disease is progressing, how they'll respond to treatment, right? And we use that to potentially discretize it with finite elements and then solve these equations forward and come up with some digital representation of how we think the world is going to evolve. So we take that observational data, we want to assimilate that data into our models so that we can tailor these general PDEs that we think govern how, for example, a tumor grows to the specific individual. If we have a model that we can then say is patient-specific, we can run it forward in time, and we can make predictions on what the prognosis might look like, what the likely course of disease is. And then if we can further say, this is how we think the treatment affects the growth of a tumor, then we can start to ask questions about, is this treatment good for you? Is there a potential alternative therapy that would lead to a better outcome for you? But of course, once you make that decision and you put that out into the real world, now you're affecting the care that the patient gets. And so this is sort of a cycle, right? This starts all over again. You acquire more data, you update your models again, you make more predictions, and then you come up with more controls. So to me, digital twins are a framework for bringing together and tying together all of these outer loop applications. And so I like this onion figure for what an outer loop application is, right? Everything starts with data from the real physical world. We acquire this observational data and we think to ourselves, what is the data generating process? What's actually happening that is causing what we're seeing? And so then we come up with some model, typically a mathematical model, and then we want to try and align our belief, our mathematical model with the data that we see, and so we get this inverse problem. We might want to do this with uncertainty quantification so that we don't just say, this is how the future is going to play out, and then when we're wrong, people say, okay, we shouldn't listen to you, right? We want to kind of hedge our bets and say, we think with this much certainty, this is what's going to happen. So this is the first outer loop, it's uncertainty quantification. And once you've connected the data to your models, a natural thing to do is say, can we better steer the system in some direction? And so now you have this control loop, this optimization under uncertainty loop. And then if you want to do everything optimal and you want to say, okay, I want to collect the best data that informs the best model, and then I want to make the best control decisions, that is optimal experimental design. And so this is something that maybe wraps around everything. This is really important for healthcare because the way that new therapies are delivered are through the clinical trial system. And so what happens with a clinical trial is you take a cohort of patients that have a disease and you say, we're going to try this new therapy. You give it to everyone. If the survivability of that cohort increases compared to the previous standard of care, congratulations, you're now the new standard of care. And so what happens when somebody comes in and presents with a disease is it's almost a lookup table, right? It's this, you have this disease, this is the standard of care. We take this off the shelf, we give this to you. That's a one-size-fits-all solution to something that is inherently individualistic. And so if we can bring the individual into the process and we can do patient-specific modeling, say we think that this is the best therapy for you as an individual, the key idea and the key hypothesis with using digital twins, right, is that optimal decision making at the individual level is going to lead to better outcomes for the entire population. What this might look like in a clinical timeline or a clinical setting, so I work on high-grade gliomas, so aggressive brain tumors. So what typically happens is you come in, you present with the disease, you're immediately taken to surgery, and so a surgeon is going to try and resect, cut out as much of that tumor as possible. You then have a couple of weeks where you recover from the surgery, and then you come in, they do some pre-radiotherapy imaging so that they know where to target the beam, and then you go on the STUP protocol. And so you're given a cocktail of chemotherapy, drugs, and radiotherapy for 6 weeks, and then they bring you in at the end to basically assess how the therapy went, right? That's not optimal because it's kind of reactive, right? You're going to get the standard of care that everyone gets, and then we're going to see how you responded to it. So instead, if you can bring them in, say maybe 1 week into the therapy, and you can image them again, and while they're still doing the therapy, you can say, how are you responding to this therapy? Is standard of care working for you? If you're responding really well to therapy, maybe we can dial back the dosage of the chemotherapy that we're giving you, we can improve your quality of life, and still be confident that we can treat your disease. If you're not responding well, maybe we need to try and look at a different therapy, right? So if you can do something a little bit more proactive than just giving the same therapy that everyone would get and then assessing how you did, this is sort of what we're trying to do. So of course, there's an inverse problem here. When we collect this data, how do we update our belief about how the world is going to work? And then how do we determine what this should be? I can't talk about all of that in one talk, so I'm just going to focus on this first outer loop here, this inverse problem. How do we connect the data? So in one sentence, to me, an inverse problem is very clear. It is, given a model and some data, can we infer what those model parameters are? So that's a little vague, so we have to kind of mathematize this a little bit. So we have to be kind of rigorous with what we mean. So we're going to assume a Gaussian noise model, and we're going to say that our data D comes from some forward model F. That's going to be our mathematical model. It has some parameters M, and then, of course, when we get observations, there's noise in them. So we're going to have some noise-generating process that corrupts this data. And so what we want to say is we want to minimize the misfit between our model and our data, subject to the noise that we know that is present in the data. This is going to be ill-posed in the sense of Hadamard, so we're going to have some kind of regularization here so that we get a unique solution. But there are 3 key ingredients to this. There's the model, there's the data, and there's the regularization. So these are the things that I'm going to try and convey to you in the talk. But first, I'm going to do a very quick example of what an inverse problem is. So this is the simplest forward model. The forward model is just the parameter, its identity. So I have this nice picture of Bevo, Hookem, and he's kind of noisy, and I want to recover him. And so what we can see here is that there are kind of 2 ends to the spectrum. If I don't trust my data that much and I rely very heavily on my prior or on my regularization, I might not be well informed enough to actually recover something meaningful. I might just kind of get my prior back. He might be blurred. On the other end, if I say I have a lot of data, I really trust the data with full confidence, and I don't inject enough structure into the problem, well then I'm still going to recover noise in my solution. So there's some balance here between the 2, and there's some Goldilocks solution that we're after where we can actually recover something meaningful. So congratulations, you're all inverse modelers now. So I'm going to walk you through, for this specific problem, the 3 sort of components. The first one is mechanistic modeling. So what is the mathematical model that we're using? Unfortunately, in computational oncology, we don't have the benefit of being able to derive these things from first principles like you might in mechanics or in fluid dynamics, right? There's no Navier-Stokes equation for us. So instead, we have to do phenomenological modeling where we focus on hallmarks of cancer, processes that we know that are occurring. 2 of the most important are the infiltration of the existing tumor core into healthy tissue, as well as the proliferation of that existing tumor core. So how does it vascularize itself? How does it give itself nutrients and other goodies to help it grow? And so these assumptions are going to yield this PD that we're going to study. So we're going to have this infiltrated term that's going to be modeled as a diffusion process where the tumor expands. And then we're going to have this proliferation term that is a logistic growth reaction term that accounts for how the tumor is going to continue to grow. So what does data look like in this setting? So I'm not a radiologist. Maybe someone in the crowd is a radiologist. If so, I would like to talk to you and have you, segment things for me. But I hope that everyone can kind of appreciate these are different modalities of MR imaging. And I hope that you can see that these show you different features of the disease, right? Some of these are telling you something about the anatomy of the patient. Some of these are telling you about which regions of the tumor might be necrotic. Some are telling you about where there's potential edema. Some are telling you something about how densely packed, how tight these tumor cells actually are in the patient. And so these are a selection of modalities that are typically acquired during routine clinical imaging, and so we want to use these to develop patient-specific models. That starts at the domain level, right? What is the computational domain that we choose to use? Everyone has a different anatomy. There are quote-unquote average brains out there that you can use as a template, but nobody has an average brain, right? Everyone is unique, and so we want to account for that. So we take these two images here, we do anatomic segmentation, and we generate a domain that's specific to that patient. We then take these other modalities that I talked about. Ideally, a radiologist can come in and segment the tumor for you and say this is where the tumor is, and then we can inform it with this apparent diffusion coefficient map that tells us something about how dense that tumor core is. And so now we have a snapshot of the patient state. And if they come in again, we do this whole process again, and we get another snapshot, and so on and so forth. And so this final component, this final ingredient, is how do we encode the structure? It's not so helpful to an oncologist or a clinician to tell them this is exactly how the future is going to play out. We want to do this in some kind of structured way, account for the uncertainty. And so we're going to use a Bayesian method. It has lots of nice properties. It guarantees us a well-posed posterior. And so that's going to be the solution that we're after. And then, of course, things like the mode can be computed scalably with Newton-Krell methods. So where that leaves us right now is that we have an implementation. We're using Phoenix for the finite elements, PETSI for the solvers, HippieLib for the inverse problem modeling. And so we can solve the dynamics forward. You can see the white matter, the gray matter, the tumor, the progression of the tumor. And importantly, we're trying to use public data here. We're fortunate enough to work with MD Anderson, which is a world-class cancer facility, but most patients don't go to world-class facilities for their care. And so we want to be able to develop methods that can be deployed in many different clinics that don't have access to that level of technology. And so we're using publicly available data from the Cancer Imaging Archive to do so. So the other thing about this is a nice video, but how long does this take to make, right? If this takes 3 months, this isn't actually useful to us because we can't turn something around in a clinically relevant time frame. So the spoiler is it takes about 15 minutes to simulate 6 months of disease progression, and a big enabler for that is high-performance computing. So here I'm just showing you some strong scalability plots. These were run at the TAC Frontera supercomputer, and you can see that we have very good, strong scaling for both the forward and the adjoint solves. Some of you might say 2 million degrees of freedom is not that many, but for us this resolves a lot of the fine-scale structures in the brain quite well, so we're happy with it. Weak scaling is a little bit less important for us because we're not continually refining the mesh, but the story is the same. We get very good weak scaling as well. And so when you put all of these components together, the high-performance computing to enable the forward modeling, the mathematical models that we've derived, and you connect it to the data that we have, here we're taking a 2D slice, meshing it, and then putting the tumor conditions on it. So these are samples from the prior. And so the prior isn't informed by the physics in the model, it's not informed by the data, and so you can see this is kind of jittering all over the place. This is the diffusion coefficient field. But once you solve the inverse problem and you get your posterior as the solution, it's still random, right? It's still, there's still some uncertainty here. We don't know perfectly the dynamics, but I hope you can all see it's pretty consistently lighting up this region here where the tumor is. So we're learning something about how to tailor these models to a specific individual. And then of course, now that you have a tailored model, you can run this forward many times. You can start asking questions about how would they best respond to therapy if it's targeted at this region or if we switch out the cocktail of drugs that they're receiving. I don't have time to talk about all of that today, but it's coming down the pipeline and we're really excited for it. But the key takeaway is that we think the digital twins are a framework to enable quantitative improvement over one-size-fits-all interventions. So we're trying to tailor methods to the individual so that we can make the best decisions at that level. And of course, that starts with the domain, and it also starts with being honest about what can we learn from the data, how much uncertainty is there, and what we've learned. I'm also very grateful to, I'm running a little bit over, but I want to thank all the people that make this possible, right? So it takes a village, and I'm very fortunate at UT Austin to be able to, especially at the Odin Institute, to work with a lot of amazing people from a lot of different fields, right? So my advisor, Karen, and everyone in our research group, the Center for Computational Oncology, Tom Yankelov, David Hormuth, Umberto Villa. And then I also want to thank Krell. Really, the staff is great, all the people are great. This is work that came out of conversations early into my PhD and was like, great, this is really exciting. We would love to do this. We don't have funding. So I don't think that we can do this. And then, here I am with this fellowship that, kind of lets me put my thumb on the scale and say, okay, you might not have funding, but I have funding. And so I can work on this because I find this interesting. And, I think that it's impactful work. And I don't think that it would have been possible without the CSGF. So I really want to thank Krell, by extension, the Department of Energy, for funding this. My great mentors during my practicums, Shank and Malik, and Michael Martin, if he's in the room, for setting me up with them. And with that, I will take questions.